So now we will talk about respiratory tract infections, and first we will discuss pneumonia. Pneumonia basically means infection of the lung parenchyma. This is the simplest way to describe pneumonia. And in general, pneumonia is classified into four main categories. We have first community-acquired pneumonia, then we have hospital-acquired pneumonia, then we have aspiration pneumonia, and finally we have a special type of pneumonia in immunocompromised individuals. And this classification is very important because it's according to the etiology. In each category of pneumonia, you will have special types of organisms which will be involved, and that means the antibiotic choice in the management of pneumonia will depend on the category or the type of pneumonia, whether it's community-acquired or hospital-acquired or aspiration pneumonia or pneumonia in immunocompromised patients. So first let's talk about community-acquired pneumonia. Community-acquired pneumonia, this is a type of pneumonia which develops outside the hospital. So it develops before hospital admission, or it can develop in the first 48 hours after hospital admission. So if you have a patient and this patient developed pneumonia within 48 hours after hospital admission, this will be considered as community-acquired pneumonia. Although it's developing inside the hospital, it will not be considered as hospital-acquired pneumonia, because if the patient developed pneumonia within the first 48 hours after hospital admission, it will be still considered as community-acquired pneumonia. So community-acquired pneumonia is the type of pneumonia developing in the community outside the hospital or developing within 48 hours after hospital admission. So what are the possible organisms which can be associated with community-acquired pneumonia? In general, we have two main groups of organisms which can cause community-acquired pneumonia. We have typical organisms and we have atypical organisms. So what's the difference between typical organism and atypical organisms? You must be heard previously of the term typical pneumonia and atypical pneumonia. The term typical pneumonia is a type of pneumonia caused by typical organisms, while atypical pneumonia is a type of pneumonia caused by atypical organisms. So the typical organisms which can result in community-acquired pneumonia, these are the organisms which can be demonstrated on sputum gram stain, or these are the organisms which can be detected on sputum culture. So these are culturable organisms. These are the organisms which grow on our standard bacterial cultures. While the atypical organisms are the organisms which are not culturable. These are the organisms which will not be detected on gram staining, and it will not be detected on sputum culture. These organisms will not grow on the standard bacterial cultures. It will require special culture media, or it will require special types of investigations. And for that reason, these are called atypical organisms. And there are other differences between these typical and atypical organisms. It's not just in the laboratory findings, it's not just the differences between typical and atypical organisms, it's not just according to the laboratory findings, according to the cultures, but also there are differences according to the clinical presentation of pneumonia caused by these organisms, and also there are differences in the radiological features seen with these type of infections. For example, typical organisms usually tend to cause infection which results in formation of exudate within the air spaces. It fills up the air spaces with exudate, and this will result in productive cough. While atypical organisms, the infection more commonly tend to involve the pulmonary interstitium, and it tend to spare the air spaces. So in patients who are having pneumonia due to some atypical organism, the air spaces usually are empty because the infection mainly involving the interstitium of the lungs. And for that reason, because the air spaces are empty, in patients with pneumonias caused by atypical organisms, they will usually present with dry cough. They will present with non-productive cough. Because in order to have a productive cough with pneumonia, there must be involvement of the air spaces. The air spaces must be filled with secretions and with exudate. And this happens usually with typical organisms. While atypical organisms, it tend to spare the air spaces. It leaves the air spaces empty, and it involves the interstitium. And for that reason, most likely these patients who are having atypical community-acquired pneumonia, they will present with non-productive cough. So the differences between the typical and atypical organisms also in the clinical presentation of the patient, not just according to the culture and gram staining. Along with that also, because the typical organisms tend to fill up the air spaces with exudate, this filling of the air spaces with exudate will result in formation of consolidation. It will result in consolidation of the lung tissue. And this will be detected on chest x-ray. It will be detected on radiology of the chest. While atypical organisms, because the air spaces are mainly empty and the disease mainly involving the interstitium, for that reason, when you do chest x-ray in these patients, it's not likely to detect consolidation. Usually there is no consolidation, there is no well-formed consolidation as in typical pneumonia, and instead you will detect some interstitial infiltrates. There is some interstitial inflammatory changes which will be detected on x-ray, and it usually tend to be bilateral. So typical organisms will give you consolidation on chest x-ray, while atypical organisms will not it will not give you consolidation on chest x-ray. It can give you interstitial infiltrates, which can be bilateral. So there are different ways by which we can differentiate between typical and atypical organisms. But the general rule, typical organisms are those organisms which can be culturable, while atypical organisms are those organisms which are not culturable. So what are these typical organisms which can result in community-acquired pneumonia? The classical typical organism and the most important and the most common cause of community-acquired pneumonia is Streptococcus pneumoniae. So Streptococcus pneumoniae is the commonest cause of community-acquired pneumonia, and it's one of the typical organisms. So in pneumonia, in community-acquired pneumonia caused by Streptococcus pneumoniae, it can be detected, the organism can be detected on sputum gram staining, and it can be detected on sputum culture, and the patient here most likely will present with productive cough because, as we said, typical organisms result in formation of exudate within the air spaces, and it most likely will result in consolidation on the lungs. When you do chest x-ray, you will detect consolidation, which is usually confined to one loop, and it's called lobar consolidation. Then there are other typical organisms like Haemophilus influenzae. Also, we have Moraxella catharalis. These are examples of the typical organisms which can result in community-acquired pneumonia. Also, we have some gram-negative bacilli like Klebsiella, for example, which is also considered as typical organism. But the most common cause of community-acquired pneumonia overall is Streptococcus pneumoniae. Then we have atypicals. We have atypical organisms which results in atypical pneumonia. The classical examples of atypical organisms, we have a bacteria called Mycoplasma pneumoniae. We have also Legionella pneumophila, and we have chlamydia species. We have two types of chlamydia which can result in pneumonia. The most common type of chlamydia that results in pneumonia is called Chlamydophila pneumoniae. The second type of chlamydia which can also result in pneumonia is called Chlamydia psittaci. So we have Chlamydophila pneumoniae and we have Chlamydia psittaci, and these are atypical organisms which can result in community-acquired pneumonia. Then also we have other organisms, other atypical organisms like Coxiella burnetii. Also we have viruses. There are a lot of viruses which can result in pneumonia, and in general, viruses are considered as atypical organisms because viruses will not grow on bacterial cultures. So these are non-culturable organisms. And so viruses are considered as atypical pneumonias, and it will give you features of atypical pneumonia. Example of viruses which can result in community-acquired pneumonia, we have influenza, we have also H1N1, we have sometimes also can have herpes simplex virus or measles, can resulting in pneumonia, and also we have coronaviruses, and nowadays we have the epidemic of COVID-19, which is caused by the novel coronavirus. So coronaviruses are considered as atypical organisms which will result in atypical pneumonia. And for that reason, patients with COVID-19, they tend to present with dry cough rather than productive cough, because as we said, atypical organisms more commonly involving the interstitium of the lung, and it usually spares the air spaces. And for that reason, the patient usually will not have productive cough. The patient will usually present with dry cough. So these are the possible causes of community-acquired pneumonia. So remember that community-acquired pneumonia can be either caused by typical organisms or with atypical organisms. And the most common cause of community-acquired pneumonia overall is Streptococcus pneumoniae. Then there is the second category of pneumonia, which is hospital-acquired pneumonia. Hospital-acquired pneumonia can be defined as a type of pneumonia developing after more than 48 hours after hospital admission. So if you have a patient who is hospitally admitted and the patient developed pneumonia after 48 hours from hospital admission, this will be considered as hospital-acquired pneumonia. And here, the organisms which result in hospital-acquired pneumonia are different than the organisms commonly associated with community-acquired pneumonia. In community-acquired pneumonia, we say that the most common cause is Streptococcus pneumoniae. But in hospital-acquired pneumonia, Streptococcus pneumoniae is not the most common cause. Here, the condition most commonly caused by gram-negative bacilli or Staphylococcus aureus. Gram-negative bacilli, especially the enteric gram-negative bacilli. These are the gram-negative bacilli which are part of the intestinal flora. And these enteric gram-negative bacilli include organisms like E. coli, also Klebsiella, Proteus, and even hospital-acquired pneumonia can be caused by Pseudomonas, which is another gram-negative bacilli. So one of the important groups of organisms associated with hospital-acquired pneumonia are gram-negative bacilli, like E. coli and like Pseudomonas. Then also, patients with hospital-acquired pneumonia, also, they can develop pneumonia due to Staphylococcus aureus. And it can even include methicillin-resistant Staph aureus, which is a very nasty organism that requires specific types of antibiotics. So the spectrum of organisms associated with hospital-acquired pneumonia are different than the organisms associated with community-acquired pneumonia. Here in hospital-acquired pneumonia, there is the most likely causes are gram-negative bacilli, like E. coli and like Pseudomonas, and also Staphylococcus aureus, even including methicillin-resistant Staph aureus. And for that reason, your antibiotic choice, if you have a patient with hospital-acquired pneumonia, your choice of antibiotic in the treatment should cover these two groups of organisms. It should cover gram-negative bacilli, especially Pseudomonas. You should give an anti-pseudomonal antibiotic, and also you should give antibiotics which will cover Staph aureus, including the resistant type of Staph aureus, which is methicillin-resistant Staph aureus. You can give antibiotic like vancomycin, for example. Then we have the third category, and this is a special category which is called expiration pneumonia. This type of pneumonia can occur on community basis, and it can happen develop outside the hospital, or it can happen inside the hospital. It can be considered sometimes as a subtype of hospital-acquired pneumonia as well. And this type of pneumonia occurs due to aspiration of some endogenous oropharyngeal secretions. Either there is aspiration of some endogenous secretions, and these endogenous secretions might be oropharyngeal secretions, or it might be even some gastric secretions. When these secretions are aspirated into the lower respiratory tract, it can result in a special type of pneumonia which will be called aspiration pneumonia. Or sometimes aspiration pneumonia can develop due to aspiration of some exogenous material. So aspiration pneumonia is due to aspiration of endogenous or exogenous materials into the lower respiratory tract. And this type of pneumonia is considered as suppurative pneumonia. It will be caused by organisms which will produce pus. It will be caused by pyogenic organisms. And these organisms will result in suppurative necrotizing pneumonia. And eventually, this suppurative necrotizing pneumonia, if it's not treated properly, it can be complicated with lung abscess. So since it's caused by pyogenic organisms, that means there is a possibility that aspiration pneumonia will eventually progress or can be complicated by lung abscess. And if it's not treated and it persisted for a long time, even it can result in bronchiectasis. For that reason, aspiration pneumonia is very important to be diagnosed and to be treated aggressively. And here, the most likely organisms associated with aspiration pneumonia, as we said, it's most likely due to aspiration of some endogenous secretions, like the oropharyngeal secretions. And so the most likely organisms are the organisms which are part of the oral cavity and the upper respiratory tract flora. The organisms which are normal commensals within the oral cavity and within the upper respiratory tract are the same organisms which can result in aspiration pneumonia, because with the aspiration of oropharyngeal secretions, these secretions will contain these type of flora, these types of bacteria which are normal commensals within the oral cavity and the upper respiratory tract. And these bacteria include aerobic as well as anaerobic bacteria. But the most important group of organisms which are associated with aspiration pneumonia are anaerobes. Oropharyngeal anaerobes. These are the organisms which are part of the oropharyngeal flora. And these are the organisms which will be aspirated, and it can result in pneumonia. So aspiration pneumonia most commonly associated with anaerobic bacteria, but it can be also associated with aerobic bacteria like gram-negative bacilli, including Pseudomonas and Klebsiella. So the possible organisms which can result in aspiration pneumonia are the organisms which are part of the oropharyngeal flora, and this includes anaerobes, and also it includes gram-negative bacilli like Klebsiella and Pseudomonas. So again, your antibiotic choice here in the management of aspiration pneumonia should cover anaerobic bacteria, and it should cover also gram-negative bacilli. So what are the predisposing conditions for aspiration pneumonia? Because not anyone can develop aspiration pneumonia. Aspiration pneumonia develops due to multiple predisposing factors. One of the important predisposing conditions is impaired consciousness. Patients with impaired consciousness will have depressed cough reflex. The important mechanism which will prevent aspiration of endogenous or exogenous materials or secretion is the cough reflex. And the cough reflex in general is depressed in patients who are having impaired consciousness due to any cause. So impaired consciousness, whatever the underlying cause, it will depress the cough reflex in the patient, and the patient will be prone to develop aspiration pneumonia. So examples of the conditions which result in impaired consciousness, we have seizures, patients with seizures, generalized seizures in which the consciousness is impaired. Also patients who are having stroke, with massive stroke, usually the consciousness will be impaired. Also patients with intracranial hemorrhage, patients with head trauma, patients with intoxications, for example, alcohol intoxications or alcohol withdrawal with confusion, or any form of drug intoxications which can impair the consciousness, or patients with hypoglycemia. So any condition which can result in impairment in the consciousness level can predispose to aspiration pneumonia due to depressed cough reflex. Then we have also other predisposing condition in which there is bulbar weakness, there is bulbar palsy. Whenever there is weakness in the bulbar muscles, and these are the muscles which are involved in swallowing, when there is impairment in swallowing, this can also predispose in aspiration. And there are a lot of conditions which can result in bulbar weakness or bulbar palsy. These are neurological diseases. For example, patients with Parkinson's disease, advanced Parkinson's disease can also be complicated with bulbar weakness. Also patients who are having motor neuron disease. Motor neuron disease can involve the bulbar muscles. Also patients who are having neuromuscular junction disorders like myasthenia gravis. They can have also bulbar palsy. And patients with Guillain-Barré syndrome. They've got neurological conditions which impair the bulbar muscles, neurological conditions which are associated with bulbar palsy can predispose to aspiration pneumonia. Also patients who are having stroke. Stroke, especially stroke involving the posterior circulation, can also result in bulbar palsy. And this can be complicated with aspiration pneumonia. And actually one of the important cause of death in patients with a stroke is aspiration pneumonia. And it's due to combination of bulbar palsy, and also it can include impaired consciousness. Then also we have another important predisposing condition, which is poor dental hygiene. And as we said, aspiration pneumonia is usually due to aspiration of the organisms which are part of the oral cavity commensals, and organisms which are part of the upper respiratory tract commensals or normal flora. So if someone has poor dental hygiene, also this can predispose to aspiration pneumonia. Then eventually, patients with disorders of the upper GIT, disorders of the upper gastrointestinal tract. For example, patients who are having esophageal disorders like achalasia, or there is mechanical obstruction with esophageal cancer, or patients who are having severe gastroesophageal reflux disease. These patients can develop aspiration pneumonia due to aspiration of gastric acid, of gastric secretions. And patients who are having gastric problems, patients with gastric tumors or with severe GERD, as we said. So upper gastrointestinal tract disorders can be considered as also predisposing factors or predisposing conditions for aspiration pneumonia. So as we said, the most likely organisms associated with aspiration pneumonia are anaerobic bacteria and gram-negative bacteria, gram-negative bacilli. Then the final category of pneumonia is called pneumonia in immunocompromised hosts. If you have a patient who is immunocompromised, whatever the cause of immunosuppression, for example, patients with HIV or patients on chemotherapeutic drugs, whatever the cause of impaired immunity, in those patients, still the most common causes are the same organisms associated with community-acquired pneumonia. So immunocompromised patients are more likely to develop pneumonia due to typical organisms like Streptococcus pneumoniae. Still, Streptococcus pneumoniae is considered as the most common cause of pneumonia in immunocompromised individuals. But the most important point here, in this category of patients, they are prone to develop pneumonia due to some opportunistic infections. And these opportunistic infections will not cause an infection in immunocompetent individuals. These are types of organisms which will cause infection in immunocompromised individuals. Examples of opportunistic infections which can result in pneumonia in immunocompromised patients, we have special type and important type of protozoa or fungus called Pneumocystis jirovecii. And as we discussed previously in HIV, Pneumocystis jirovecii is one of the important and opportunistic organisms or infections involved in patients with AIDS, especially those patients who are having CD4 count less than 200. So one of the important causes of pneumonia in immunocompromised patients, which should be kept in mind, is Pneumocystis jirovecii, which will result in pneumocystis pneumonia. And Pneumocystis jirovecii itself is considered as atypical organism. It's one of the atypical organisms. It will not grow on standard cultures. It will require special testing. Then also there are other fungal infections which can also result in pneumonia in immunocompromised patients. For example, fungal infections like histoplasma. Also, we have some viruses which will not usually cause pneumonia in immunocompetent individual. It will cause pneumonia in immunocompromised individual like cytomegalovirus. Cytomegalovirus is one of the opportunistic viruses, also especially in patients with AIDS. And also we have some mycobacteria, like Mycobacterium tuberculosis. Patients who are immunocompromised, they can develop pneumonia due to Mycobacterium tuberculosis. And Mycobacterium tuberculosis, it tends to cause chronic pneumonia, as we discussed. So when you talk about pneumonia in immunocompromised patients, remember that still the most common cause is Streptococcus pneumoniae. Still those patients will develop pneumonia due to the organisms associated with community-acquired pneumonia in general. But they are more prone to develop pneumonia with opportunistic infections, like Pneumocystis jirovecii, like cytomegalovirus, and like mycobacteria. So these are the main categories of pneumonia. Then let's try to talk about special organisms which are associated with community-acquired pneumonia in general. Let's try to compare between the typical and atypical organisms, and let's talk about the associations between each one of these organisms. So the most important typical organisms which can cause community-acquired pneumonia include Streptococcus pneumoniae, which is the commonest cause. Also, we have Haemophilus influenzae, we have Moraxella catarrhalis, and we have Klebsiella, and we have Staphylococcus aureus. These are all typical organisms. These are organisms which can be demonstrated on gram stain, and these are organisms which can be cultured. These are culturable organisms. So let's see what are the important associations with each one of these organisms. When you talk about pneumonia due to Streptococcus pneumoniae, which is called pneumococcal pneumonia, this type of pneumonia affects all age groups, but it's more common in elderly patients. And it's more common also in alcoholics. And it's more common in patients post-splenectomy, patients who are having hyposplenism, reduced splenic function, either due to post-splenectomy or maybe patients with sickle cell anemia, who are prone to develop autosplenectomy. In those patients who are having reduced or impaired splenic function, they are prone to develop pneumonia due to Streptococcus pneumoniae. So Streptococcus pneumoniae is the most common cause of community-acquired pneumonia overall, but those patients who are having hyposplenism or post-splenectomy patients are having even extra risk. They are at higher risk to develop pneumonia due to Streptococcus pneumoniae because the spleen is required for the removal and elimination of encapsulated organisms like Streptococcus pneumoniae. It's one of the encapsulated organisms. And these organisms will require normal and healthy spleen in order to be eliminated. So those patients who are not who are having impaired splenic function, or those patients post-splenectomy, are prone to develop infections with encapsulated organisms due to reduced ability of the body to eliminate these organisms, like Streptococcus pneumoniae. So they will be prone to develop pneumonia due to Streptococcus pneumoniae. They will be also prone to develop, for example, meningitis, which can be caused by encapsulated organisms like Streptococcus pneumoniae also, or Neisseria meningitis, which is also another encapsulated organism. So when you talk about Streptococcus pneumoniae, the important associations here, remember that it's the most common cause of community-acquired pneumonia overall. It can affect any age group, but it's more common in elderly, and it's more common also in post-splenectomy patients. Then when you talk about Haemophilus influenzae and Moraxella catarrhalis, what you need to remember about these two organisms is the fact that they are associated with chronic obstructive pulmonary disease. These are the two most common causes of acute exacerbation of COPD. The acute exacerbation of COPD in most of the cases is related to infection, is related to respiratory tract infection. And it's most likely due to Haemophilus influenzae. It's the most common cause of acute exacerbation of COPD, followed by Moraxella catarrhalis. So whenever you have a type of pneumonia caused by Haemophilus influenzae or Moraxella catarrhalis, the patient might be already having COPD. So this is the important condition associated with these two organisms. Then we have Klebsiella, which is a gram-negative bacilli. Klebsiella can also result in community-acquired pneumonia. It's one of the typical organisms as well. And you should think of Klebsiella especially in alcoholic patients and in patients with diabetes mellitus. So these are the two important associations in pneumonia due to Klebsiella. And then we have Staphylococcus aureus. Staphylococcal pneumonia, most commonly seen following recent viral infection. The patient will usually report recent viral infection of the respiratory tract, especially influenza. And after influenza, the patient can develop pneumonia due to Staphylococcus aureus. So always consider Staphylococcus aureus as a possible cause of pneumonia post-influenza, after influenza, or after recent viral infection. And also Staphylococcus aureus should be considered in pneumonia in patients who are IV drug users, as IV drug users in general are prone to develop bacteremia with the Staphylococcus aureus, which is part of the skin flora. And due to bacteremia with Staphylococcus aureus, these patients can eventually develop pneumonia, or even they can develop infective endocarditis, which is more commonly tend to involve the right side of the heart. It tends to involve the tricuspid valve. So if you have a patient with pneumonia and there is also an element of infective endocarditis in the tricuspid valve, you should consider IV drug user, because it's an important predisposing condition for Staphylococcus bacteremia. So these are important associations with important typical organisms causing community-acquired pneumonia. Then let's talk about important associations with some atypical organisms. First, we have Mycoplasma pneumoniae, which is an important cause of atypical pneumonia. Mycoplasma pneumoniae is characterized by causing pneumonia in young adults and in previously healthy patients. And usually the disease caused by Mycoplasma pneumoniae, it tend to be mild pneumonia. It tend to cause mild pneumonia, and usually the patient will not seek medical advice. Patients who are having pneumonia due to Mycoplasma pneumoniae, it usually tend to be mild and the patient will not seek medical advice. But sometimes Mycoplasma pneumoniae, it can present with some extra pulmonary manifestations. Another important distinguishing feature between atypical and typical typical organisms, they will present with pulmonary manifestations, while atypical organisms, along with the pulmonary manifestations, sometimes these atypical organisms can result in some extra pulmonary manifestations. So these organisms are being atypical not just in the laboratory finding, not just in the fact that they are non-culturable, but also in the clinical presentation of the patient. They can present in atypical manner. They might not present with obvious pulmonary manifestations. They might present with extra pulmonary manifestations, like GIT manifestations, for example. So Mycoplasma pneumoniae is associated with pneumonia in young individuals and in healthy patients, patients without comorbidities, without chronic illnesses. Then we have another important also atypical organism, which is Legionella pneumophila. Legionella is associated with epidemic infection in older smokers, particularly when located near infected water sources, such as air conditioning systems. So you should always suspect Legionella-induced pneumonia whenever you have an outbreak of pneumonia in hotels, for example, or in other buildings which using air conditioning systems. Because Legionella, more commonly, the source of Legionella is from infected water sources, especially air conditioning systems. And for that reason, it tends to cause outbreaks of pneumonia in hotels, because hotels will use air conditioning systems. And sometimes it can be infected, these water sources can be infected with Legionella. So these are the important associations with Legionella. Then also we have another atypical organism, which is Coxiella burnetii. Coxiella burnetii can be considered as a zoonotic infection, which means it's an infection which can be transmitted from animals to humans. And human can get infection with Coxiella at the time when humans get in contact with animals at the time of giving birth. So that means veterinarians and farmers are prone to develop infection with Coxiella burnetii, because those individuals, they can get in close contact with animals at the time of giving birth. And the disease caused by Coxiella is called Q fever. And Q fever is not just a pulmonary disease. The patient can develop pneumonia, which is atypical pneumonia, but at the same time also there might be some extra pulmonary manifestations. And as I said, atypical organisms can give you atypical presentation with extra pulmonary manifestations. In Coxiella, the extra pulmonary manifestations might include infective endocarditis or hepatitis. But remember that the important association with Coxiella is direct contact with animals at the time of giving birth. Then we have also another important organism, which is Chlamydia psittaci. And as you said, we have two types of chlamydia which can be associated with pneumonia. We have Chlamydia Chlamydophilia pneumoniae, and this is the most common cause of pneumonia. And we have another less common type of chlamydia causing atypical pneumonia, which is Chlamydia psittaci. So Chlamydia psittaci is one of the atypical organisms, and the important association here, this type of infection can be transmitted to humans from birds, from infected birds, especially from parrots, birds, طيور البغبغاء. And the disease caused by Chlamydia psittaci is called psittacosis. Psittacosis is the condition caused by infection with Chlamydia psittaci, which is transmitted to humans from infected birds, especially parrots. Then finally we have Pneumocystis jirovecii, which is one of the atypical organisms, and it's one of the opportunistic organisms. And it's more commonly seen in HIV positive persons with CD4 count less than 200. And the patient is not on prophylaxis. In any patients with AIDS, when the CD4 count is less than 200, we should start the patient on prophylaxis against Pneumocystis jirovecii, because this infection is more common in those patients who are having CD4 less than 200. So whenever you have a patient with HIV with CD4 less than 200 and the patient is not on prophylaxis, if this patient is developing pneumonia, you should think of Pneumocystis pneumonia. So these are the important associations with the most likely organisms causing community-acquired pneumonia. Then let's talk about the clinical features and the possible complications which can be seen in the different types of pneumonias. First, you need to know that all forms of pneumonia and all forms of chest infection can give you fever and cough. So all forms of pneumonia present with fever and cough. The cough, in some cases, it can be productive. In other cases, it can be dry cough. And as we discussed previously, typical organisms tend to involve the air spaces, and it tend to fill the air spaces with exudate. And for that reason, patients who are having pneumonia due to typical organisms, they will usually present with productive cough. While those patients who are having atypical pneumonia, pneumonia caused by atypical organisms, the atypical organisms tend to involve the interstitium of the lung and tend to spare the air spaces. So the air spaces in most of the cases of atypical pneumonia will be empty. And for that reason, patients with atypical pneumonia, they usually present with non-productive cough. They present with dry cough. Then along with that also, along with the fever, patient can develop rigors or chills due to bacteremia. With pneumonia always there is an element of bacteremia. And when you have severe pneumonia, when you have severe infection, the patient also can develop dyspnea. So breathlessness or dyspnea is a feature of severe respiratory disease, not just pneumonia. Any form of severe respiratory disease can present with dyspnea. Then along with that, cough from any etiology may be associated with hemoptysis. So sometimes the cough can be blood-stained, and in some cases even the patient can present with frank hemoptysis. So hemoptysis is one of the possible presenting features with pneumonia. Then along with that, also some patients might develop chest pain in pneumonia, and the characteristic of the chest pain with pneumonia is pleuritic in nature. So patients with pneumonia, they present with pleuritic chest pain, which is a form of chest pain which tend to get worse on inspiration. Chest pain which is worsened by inspiration is considered as pleuritic chest pain. And this pleuritic chest pain is more commonly seen in pneumococcal pneumonia, in the cases of pneumonia caused by Streptococcus pneumoniae, because in pneumonia caused by Streptococcus pneumoniae, the infection might irritate the pleura around the focus within the lung and around the site of the lung infection. The pleura adjacent to the focus of the infection might get irritated by the bacteria, and there might be inflammation of the pleura, and this can result in pleuritic chest pain. Then in some cases of pneumonia, you might have some abdominal pain or diarrhea. And abdominal pain and diarrhea with pneumonia, it can be caused by atypical organisms, and as we said, atypical organism can result in extrapulmonary manifestations. Like Legionella, for example, Legionella can present like gastroenteritis. It can result in abdominal pain, diarrhea, and vomiting. But also, abdominal pain and diarrhea can occur with infection in the lower loops, irritating the intestines through the diaphragm. So if you have pneumonia involving the lower loops of the lung, it can present with abdominal pain and diarrhea, even if it's caused by typical organisms. Then let's talk about the physical signs which can develop in pneumonia. There are a lot of signs which can be detected. First, the vital signs. In patients with pneumonia, you might have pyrexia, but some patients might present with hypothermia, especially elderly patients. In severe cases of pneumonia, you might have cyanosis, which can indicate respiratory failure. Also, some patients might develop tachypnea and tachycardia. And tachypnea, increased respiratory rate, is a marker of hypoxia. Whenever you have a patient with pneumonia and the patient is tachypnic, you should think that the patient is actually hypoxic, because hypoxia stimulates the respiratory center and it increases the respiratory rate. And also some patients with pneumonia, especially elderly patients, they might present with confusion. Actually, a lot of elderly patients with pneumonia, they will not usually present with respiratory symptoms, or they might have minimal respiratory symptoms, and instead they will present with an acute confusion state. So when you have a patient with acute confusion state or delirium, you should always exclude pneumonia. And confusion is a marker of severity, of the disease. When you have confusion in pneumonia, it can be considered as a marker of severe pneumonia. Also, some patients with pneumonia might present with hypotension, and hypotension in pneumonia is multifactorial. It can be due to dehydration. Dehydration with pneumonia is due to insensible losses. There are excessive insensible losses. Also, some patients with pneumonia might have vomiting and diarrhea, which can result in dehydration and hypovolemia, and this eventually can result in hypotension. Also, there might be reduced oral intake, especially in elderly patients with confusion. They will have poor oral intake, and they are very sensitive to develop dehydration and hypotension. Also, hypotension with pneumonia can be due to septicemia and septic shock. It can give you hypotension. So hypotension is an important sign which should be detected in patients with pneumonia. You should always check the blood pressure because it indicates severe disease. Then along with that, after that, when you do chest examination, you might be able to detect signs of consolidation. And these signs of consolidations are more commonly seen in cases of pneumonia caused by typical organisms, because remember, consolidation of the lungs is due to filling of the air spaces with exudate, with pus, and this happens with typical organisms. Atypical organisms, usually it involves the interstitium of the lung, and it will not result in clear consolidation in the lung. And for that reason, if you have a case of atypical pneumonia, you might not detect signs of consolidation. These signs of consolidation might include features like increased tactile vocal fremitus. It might include also dullness on percussion at the site of the consolidation. It might include also bronchial breath sounds, bronchial breathing. It might include also increased vocal resonance. All these are features of consolidation. And along with that also you might detect features of pleural effusion. There are some cases of pneumonia, especially pneumococcal pneumonia, which can be complicated with pleural effusion. There is effusion around the focus of the infection, around the site of the consolidation, and this is called parapneumonic effusion. And sometimes even some cases of pneumonia can be complicated with empyema, which is infected effusion, which is pus within the pleural space. And so you might be able to detect signs of pleural effusion or empyema on physical examination. You will have stony dullness on percussion. You will have reduced breath sounds at the site of the effusion. You might have shifted trachea as well due to massive effusion. And you might detect also pleural rub in some cases. So these are the physical findings which can be detected in pneumonia. Then let's try to compare between two special types of organisms causing pneumonia, including Mycoplasma pneumoniae and Legionella pneumophila. These are two important causes of atypical pneumonia. Let's see what are the possible features which can be seen in pneumonia due to Mycoplasma pneumoniae and in pneumonia due to Legionella pneumophila. And as we said previously, atypical pneumonias can sometimes present with systemic features, with extrapulmonary features. So when you compare between these two, we will try to know what are the possible extrapulmonary features which can be seen with each one of these two organisms. First, when you talk about Mycoplasma pneumoniae, it tends to present insidiously with flu-like symptoms like headache, myalgia, and arthralgia, followed by dry cough. And this is actually the most likely scenario. Patients with Mycoplasma pneumonia, they tend to have mild disease. They will have flu-like symptoms like headache, myalgia, and arthralgia, which can be followed by dry cough. They will usually not seek medical advice, and they will improve on their own in most of the cases. It's unlikely to have a patient with Mycoplasma pneumonia presenting to the hospital. And those patients with Mycoplasma pneumonia presenting to the hospital, it's most likely these patients will have some extrapulmonary manifestations. So they will have complicated disease. So what are the extrapulmonary manifestations which can be seen in some uncommon cases of pneumonia due to Mycoplasma pneumoniae? One of the important extrapulmonary manifestations are cutaneous, mucocutaneous manifestations. There are different types of skin rashes which can be seen with Mycoplasma pneumoniae, but the two important types of skin rashes include erythema multiforme, which is a form of target-like lesions. Here you will have erythematous, target-like lesions, usually on the peripheral part of the body, especially in the hands. And erythema multiforme is not specific for Mycoplasma infection because it can be seen with many other conditions. For example, it's more commonly seen as a reaction to drugs, like sulfa drugs. Or it can be seen also with other forms of infections, not just Mycoplasma pneumoniae. Or it can be seen even with some connective tissue diseases, or with some inflammatory conditions like sarcoidosis. And sometimes even it can be idiopathic. So erythema multiforme is not just limited to Mycoplasma infection. It's one of the features of Mycoplasma pneumoniae, but it can be seen with other conditions. Then we have more serious, and one of the dermatological emergencies can be seen with Mycoplasma infection, and this condition is called Stevens-Johnson syndrome. Stevens-Johnson syndrome is more commonly seen as a severe reaction towards specific drugs, especially sulfa drugs. But Stevens-Johnson syndrome also can be seen as part of the extrapulmonary manifestations in pneumonia due to Mycoplasma pneumoniae. And here the patient will have diffuse blistering skin rash, also associated with mucosal involvement. So Stevens-Johnson syndrome is not just a skin disease, there is also mucosal involvement. And as we said, it's not just caused by Mycoplasma pneumoniae. It can be caused as a reaction towards drugs. It can be caused also with other types of infections, and it can be caused also with some systemic conditions as well. Then after that, we have an important condition which is called bullous meningitis. Bullous meningitis is a form of ear infection. It's a form of otitis media or ear infection, which can be seen also in association with Mycoplasma pneumoniae. Here, the patient will have some painful blisters on the tympanic membrane. And the characteristic finding in bullous meningitis is painful blisters or vesicles on the tympanic membrane. And this condition also is not just specific for Mycoplasma. It can be seen with some viral infections. It can be seen also with streptococcal infections as well. So bullous meningitis is a form of extrapulmonary disease, which is extrapulmonary manifestation, which can be seen with Mycoplasma pneumoniae. Then also Mycoplasma pneumoniae can result in hematological manifestation in form of autoimmune hemolytic anemia. So if you have a case of pneumonia associated with autoimmune hemolytic anemia, you should think of Mycoplasma as a possible cause. Then also we have some CNS, we have some neurological manifestations which can be seen with Mycoplasma pneumoniae. Some patients might develop meningoencephalitis, and some patients might develop transverse myelitis. And some unfortunate patients, they can also develop Guillain-Barré syndrome. So Mycoplasma pneumoniae is one of the organisms which is linked with Guillain-Barré syndrome. And finally, also, there might be hepatitis. And hepatitis not necessarily to be clinically obvious, and the patient might not present with jaundice or abdominal pain. It might be subclinical hepatitis detected only when you do LFTs. You will find that the patient is having asymptomatic elevation in the hepatic enzymes, and there is also elevation in bilirubin, but not to the extent of causing jaundice. So these are the possible extrapulmonary manifestations which can be seen with Mycoplasma pneumoniae. Then when you talk about Legionella also initially it can result in flu-like illness, which will be followed by dry cough, similar to Mycoplasma pneumoniae. And a lot of patients will just stop at this point. But some patients also might have some extrapulmonary manifestations. The extrapulmonary manifestations associated with Legionella are more commonly GIT manifestations, and it can present similar to gastroenteritis with abdominal pain, vomiting, and diarrhea. Also, the patient might have headache and confusion. There might be also a neurological feature in form of confusion, and this is also part of the extrapulmonary manifestation with Legionella. And sometimes also Legionella can result in acute kidney injury because it involves the interstitium of the kidney. It can result in acute interstitial nephritis, and this eventually results in acute kidney injury. So the cause of acute kidney injury in pneumonia due to Legionella is due to acute interstitial nephritis. So these are the extrapulmonary features seen in Legionella pneumonia caused by Legionella. So remember that atypical organisms can give you some atypical presentation, can give you extrapulmonary manifestations. And also, for example, if you have pneumonia due to Pneumocystis jirovecii, which is another atypical organism, it can also result in extrapulmonary manifestations. You might have hepatosplenomegaly with Pneumocystis jirovecii. Also, in cases of Coxiella, in addition to pneumonia, the patient might be having features of infective endocarditis, or it can also result in hepatitis. So atypical organisms, one of the features which can differentiate atypical organisms from typical organisms is the fact that atypical organisms can present with extrapulmonary manifestations. As you can see here, this is the erythema multiforme, which can be seen in Mycoplasma pneumoniae, and it's described as erythematous target lesions or target-like lesions. Here, it's more commonly seen in the peripheral parts in the body, as you can see here, multiple skin lesions. But it's not just limited to Mycoplasma infection, it can be seen with many other conditions. Then let's talk about the complications which can be seen with pneumonia in general. We have two groups of complications. We have local complications and we have also systemic complications. The local complications which can develop in pneumonia can include, number one, pleural effusion. And as we said, pneumococcal pneumonia is more commonly associated with pleural effusion compared to the other organisms. And in pneumococcal pneumonia, the effusion is called parapneumonic effusion because it's an effusion around the focus of the pneumonia, and it tends to be mild effusion. But in some cases, some types of organisms might result in massive effusion, and it might result in formation of pus within the pleura, within the pleural space. And this is called empyema. And it's one of the serious complications in pneumonia. And it should be suspected whenever you have a patient with pneumonia who is non-responding to treatment, when you have unresolving pneumonia, or you have a patient with recurrent fever despite antibiotic therapy. You should think that the patient is having some complications like empyema. And in empyema, you need to do thoracocentesis. You need to do pleural aspiration. And the pleural fluid in empyema will characteristically, it will be exudative effusion. It will show an exudate, yani with high protein concentration, and it will have low glucose concentration and high LDH, and it will have pH less than 7.2. So whenever you have an exudative effusion with pH less than 7.2, you should think of empyema. And this condition will not just resolve with antibiotic therapy. It will require, it's one of the indications for chest tube insertion. Whenever there is empyema, you should always insert a chest tube. Then also, some types of pneumonias are suppurative pneumonias or necrotizing pneumonias, in which the organisms can eventually result in formation of some lung abscess. So lung abscess is one of the important localized or local complications seen with pneumonia. And this is especially seen with aspiration pneumonia, which is caused by anaerobic organisms and by gram-negative bacilli. And all these organisms can result in suppurative pneumonia. So lung abscess can develop as a complication of suppurative pneumonia. Then we have respiratory failure. In pneumonia, it's usually type 1 respiratory failure. And then we have the systemic complications, which can include septicemia, and it can result in septic shock and hypotension. Also, the patient can develop acute renal failure, and it has multiple causes. Acute renal failure in pneumonia, it can be due to prerenal azotemia, due to renal hypoperfusion. And this renal hypoperfusion is due to dehydration. And as we said, dehydration due to insensible losses and due to vomiting and diarrhea and reduced oral intake in some patients. Also, this renal hypoperfusion can be due to sepsis. Sepsis results in systemic vasodilatation, and this will result in renal hypoperfusion. And eventually, this will precipitate acute kidney injury or acute renal failure, which will be considered as prerenal acute kidney injury. And in some rare cases also, if you have a pneumonia due to Legionella can directly damage the kidney, resulting in acute interstitial nephritis, which will eventually result in acute renal failure. Then we have also metastatic infection. Sometimes the infection can spread, can have hematogenous spread of the bacteria from the focus of the infection in the lung to distant sites. It can go to the brain tissue, and it can establish brain infection resulting in brain abscess. It can result also in meningoencephalitis. There are some cases of pneumococcal meningitis which are preceded by pneumonia, because Streptococcus pneumoniae, which is the most common cause of community-acquired pneumonia, is also an important cause of meningitis. So sometimes the source of pneumococcal meningitis can be from a primary focus in the lungs. So metastatic infection is one of the rare complications, one of the rare systemic complications of pneumonia. And there are some cases of pneumonia which are followed by pericarditis, and also some patients might develop atrial fibrillation. And atrial fibrillation in association with pneumonia, it tends to be transient, and it's usually resolved after treatment of pneumonia. When you treat the pneumonia, the condition will resolve. It will not be chronic atrial fibrillation.